Bonjour tout le monde, mon nom est Yanick Labrie, je suis économiste de la santé. C'est moi qui ai géré comme modérateur à ce panel. I'm not sure if you're aware. Welcome first. The panel is going to be in English. Hope you're all correct with that. So we have a great list of experts with us this morning. I'm going to introduce you to them in a minute. First of all, we're going to start with Dr. Jean-Frédéric Lévesque. Jean-Frédéric Lévesque is Deputy Secretary for Clinical Innovation and Research and CEO of the New South Wales Agency for Clinical Innovation in Australia. Welcome.
Thank you. Merci.
Born and raised in Port-Cartier, Quebec. So, second panelist, we have John Sinclair. John is president of Novari Health, a dynamic and growing e-health software application company located in Kingston, Ontario. Welcome, John. Nice to have you. Then we have Dr. Pierre Gagné, nuclear physician by training, professor at the Faculty of Medicine at the University of Montreal, and medical consultant for PowerHealth Solutions. Welcome, Pierre. And last but not least, we have Dr. Roger Grégoire, colorectal surgeon, assistant director at the Centre Hospitalier Universitaire de Québec. Welcome, Roger. So our panel is divided in three parts. First, we're going to have a presentation, an opening presentation by each of our panelists, beginning with Dr. Lévesque, about 5 to 10 minutes each. And then we're going to have a second round of questions with our panelists about how to find ways to improve access to surgical care in Quebec. So, Dr. Lévesque, it's your turn.
Merci Yannick. Bonjour tout le monde. Quelques mots en français avant de poursuivre la présentation en anglais. C'est un plaisir d'être de retour au Québec pour la rencontre. Donc, j'aimerais remercier les organisateurs pour l'invitation. Alors, je vais parler aujourd'hui de notre expérience en Nouvelle-Galles du Sud, en Australie, donc l'État où Sydney est localisé, et là où je travaille donc depuis les 10 dernières années. So I'm going to share a few experiences that relate to our work in the surgical area, and my presentation will be mostly just looking at some data that relates to our current situation, and of course the impact that the pandemic has had on surgical care, which, of course, has affected many different countries. And then I'm going to talk about some of the ways that we're using to tackle the current challenges that we have. So let's start with data. I really like measurement, as many of you would know, and I really do believe that it's a good way to start to focus on innovation as well. This is a long-term trend in terms of the surgical wait list, which is the line that you can see at the top, and at the bottom is the volume of surgical procedures that we do across different quarters since 2010. And you can see that we've got one line which is gradually increasing. That's the wait list line, from 65,000 patients to a bit above 80,000 patients just before the pandemic, and then a line that goes up and down according to different quarters in terms of the volume of surgical procedures that we do. And then, of course, we've got two arrows, which represents the two waves of, or the two significant moments for Australia in terms of COVID-19. So the alpha wave was an important one, or one of the first time we had COVID in our country, and that's when we closed hospitals like many different countries did. And you can see the drop in surgical procedures performed to 35,000. And then the list, of course, shot up to 101. And then we got back to where we were quite quickly by really increasing productivity and using some of the private hospitals, and I'll talk a bit more about that. And you can see that we raised the volume of surgical procedures to 64,000. And then the Delta and Omicron wave arrived, and we had again to deal with COVID-19. But since then, just trying to be more productive is simply not working. We're not going back to the level of productivity that we had before. This is the number of elective surgeries that we contracted to the private hospitals. And let me just clarify straight away that This is not all of the elective surgeries provided in the private sector in Australia. Australia has got a very well-established private sector, and around half of elective surgeries happen in the private sector anyway. These are elective surgeries for public patients that were contracted out to the private sector to lift our volume of activity, and you can see that at 4,600, it's around of a lift of 10% that we did through contracting to private hospitals. All elective surgery, all other elective surgeries in private hospitals were closed during the pandemic as well. And this is the last data slide I wanted to show, and this is the number of patients that are overdue according to clinical criteria from 2017, and then of course with that dotted line in the middle after the pandemic episode. And what you can see is that for all emergency categories, we lived a first wave of many patients unfortunately not receiving their surgery on time compared to the really high performance that we had maintained before. And now you can see that we're really, and of course the line is a bit lower now because we're on a downward trajectory, gradually getting back to normal, but with a significant backlog of surgery. I just wanted to say one word about the current evidence around waitlist management, because of course that's the kind of literature that we looked at to design our programs and adjust some of the programs that we have to manage surgical waitlist. And on the left-hand side, you've got what the literature suggests are approaches with consistent positive evidence with regards to the effectiveness in managing the list. So of course, if you can target funding, if you've got capacities to mobilize other facilities like private facilities, prioritizing patients, pushing same-day surgery and discharge, streamlining pre-admission processes, more role for non-physicians, clinicians as part of that pathway, standardized treatment pathways, improvement methodology, and then regular validation of wait lists. Those are the things that really the literature suggests are consistently effective. And then on the right-hand side are those that there's limited but promising evidence. And that's where you see patient's choice, centralization of elective surgeries and surgical scheduling, efficient use of ORs, fast-tracking programs, and family doctors-led surgeries. And I just wanted to show this slide to show that, of course, there's promises in trying to be more productive, more efficient, and optimizing the pathway to surgery. But there's a lot that we need to do in terms of the relevance of surgery and how we prepare patients for surgery to actually tackle the wait list as well. And that's where we've got a longer-term objective as well as the short-term things that we can do to optimize the trajectory. The way we do that in New South Wales, and I just have this slide and another one, is that we try to talk with clinicians about the surgical value chain. We've got a value-based approach in New South Wales, and what we're trying to do is that at every stage we maximize value for patients and for the system. It starts with patients' needs. We know that there's surgery that's being performed that's not indicated, and therefore we need to have a discussion around low-value surgery. We've got programs for that. We know that we don't always use the best option to treat patients, going open surgery instead of laparoscopic surgery, not going to day surgery when we can do that. We know that the process actually needs also to be optimized. And of course, that's the one that we think about first and foremost when we want to manage the list. But it's just one part of the value chain. Surgery has to be provided in a proficient way. Of course, we don't want to have to do redos and things like that. And of course, in terms of procurement, we also need to make sure that we really minimize the cost of surgery to generate more value by standardizing the cost of prosthesis, for example. That's the system perspective, and that's the perspective really of having that conversation with clinicians about getting them really to maximize value at each of the stages of that framework. And then there's all of the things that we do to try to improve care and transform healthcare. And we do that by using a surgical pathway approach, where it starts, of course, from the primary referral and the decision to have surgery or not. It goes to the stages of surgical review and risk assessment, optimization of the patient before surgery, the actual operation, the recovery, and the post-acute care. And what you can see there are a list of programs that we have in New South Wales to really try to have an approach that tackles all of the stages in the pathway. Not necessarily that we do with every single hospital all of those activities, because that would be too much. We need to prioritize according to what is the real need locally, but we always need to consider the fact that, you know, it starts from referral and it ends with primary care referral back, and we need to do things that go and cut across the pathway. And that's, of course, the angle that we take to really try to address the current surgical challenges that we have. And that's what I wanted to share with you before the panel. Thank you.
Dr. Lévesque, thank you very much. Very interesting. Before letting John continue, I just want to tell you, and I should have mentioned it at the beginning, you can ask questions at the very end. Feel free to ask your question in French. Donc, vous pouvez poser vos questions en français. And that's it. So, John?
Okay, merci. And this is a great segue because your content lines perfectly with what we're about to talk about. And I've got a few too many slides, so I'm going to try and go through this as quickly as possible and introduce three concepts for discussion after. So the first one is that Canada is an underperforming country. I would say this before the pandemic, and most Canadians, certainly not in healthcare, would not really take that at face value. There's lots of academic research to say how poorly we're performing. This has not really changed in a meaningful way in the last 20 or so years. So finally, the media, Canadians are beginning to understand how poorly we perform. And it's not unique to Canada. We just heard about New South Wales, where I am also there often. And this is, I just got back from the UK, at a conference in the UK, and they're dealing with the same problems. Ireland, the same problems. English Canada, the same problems. Continental Europe, the same problems. So this is apropos right across the world, especially in publicly funded universal healthcare systems like we have in Canada. So the second theme is around how central intake models, and you had on your presentation around validating wait lists. So, one of the best ways is to manage a wait list is not have the patient on the wait list in the first place. And a lot of patients are on wait lists that shouldn't be there, and they could have been filtered out earlier in the process with the triage step in the workflow. So this is how typically referrals are done. When I say Canada, what I will mean is English Canada. I'm not an expert on the Quebec healthcare system. But most referrals are sent from primary care to secondary care by the fax machine. The fax machine today we saw in the plenary session was fantastic. I love seeing it there. I thought we were going to take a sledgehammer and hit it. You see lots of that done now on YouTube videos. But that's how, and that's slowly, not slowly now, it's actually the pace of change is picking up where we're going to retire the fax machines. But direct referrals where primary care sends a referral, specialists receive referral, that's the standard model. An alternative model, and this is what it looks like when you do that, right? You end up sending referrals, not really knowing where the best provider is, specialty, subspecialty, what the travel distance is for the patient, what the wait time is for each of those providers. All of those factors should be factored into where referral is sent in the first place. Private industry does not use this model. Why? Because you line up for Air Canada or WestJet or Porter Airlines. You don't line up like this typically. It's not an efficient way to manage your resources. You're not load balancing demand across all available resources. A central intake model, and I'm aware of the CRDS in Quebec and its benefits and some of its challenges, but this is a central intake model. It's what industry does. It's what I already quoted the airline industry. It's much more efficient for the healthcare system. You're load balancing the demand, patients, across all available resources. Those resources can be individual specialists, they can be clinics, they can be medical imaging centers doing MRIs or CT or other modalities. It's just a better way. The academic research is overwhelmingly positive of that model. This is an example of one example of something that was actually mandated in the province of Ontario. In Ontario, they ordered that primary care physicians are no longer allowed to send a hip or knee replacement referral directly to an orthopedic surgeon. Instead, the 14 regions at the time of the province were mandated to set up this model here. It's a bit of an oversimplification, but a referral form goes not to a specialist and not to a hospital. It goes into a central intake program similar to the CRDS. The difference here is that the referral is then sent, again, not to the surgeon, not to the hospital, but to a rapid assessment clinic where the patient shows up. The patient is seen by often a retired orthopedic surgeon who's working part-time, no longer in the operating rooms, or more commonly by an advanced practice physiotherapist who works in collaboration with the surgeons. And there's that triage assessment. About, give or take, about 70% of patients then go on to the next step in the process because they are a surgical candidate, and about 30% are sent back to primary care with a clinical note from the assessor indicating other treatment options for the patient. So that's one model. This is another model, not surgery, but mental health. And this is in the Mississauga-Halton region, so the western half of outside of Toronto. It's a population of 1.2 million people. They recognize that often primary care physicians are challenged with making accurate diagnosis for mental health and addictions concerns. But the real challenge is, where do you send the patient? So they set up a central intake program. They have mental health nurses. They literally phone every patient. They conduct a 30-minute assessment. They then determine what are the appropriate clinical resources for that patient. In 70% of the referrals that come in, after the assessment is done, they determine that that patient doesn't need one referral, but they need multiple referrals to multiple providers. Some of them are, yes, acute care hospitals. Others are agencies in the community providing a basket of services. So again, a different model, the same basic concept being applied. And the last theme is surgical waitlist management. So as we saw in your slide deck, you had the list on the right, list on the left. Some are more effective than others. There is no silver bullet to solve this problem of access to care for surgery. It's a bunch of little things that collectively make this up. And one of them is data, and having accurate data, who's waiting for what, where they're waiting. So this is a recent announcement by the province of Ontario that is implementing a solution. It's called a regional hub, and that hub basically does four things. It's taking data from all of the hospitals in the region, of which there are about 15. It's creating a consolidated master wait list of every patient waiting for every type of elective surgery. So you now have a master wait list, and now these hospitals can now start beginning to coordinate their services, and it can also influence where we're going to send patients. Where is their capacity in the system? So you layer on analytics on top of that. You then put some GIS mapping on top of those analytics so that you can easily convey to the population and to healthcare providers and to the government, the funders, of where resources are needed to alleviate the problem. And then finally, the ability to transfer patients. Certainly in most of Canada, when you're on a wait list for a surgical procedure at a hospital, you're on a surgical wait list at that hospital and that hospital alone. No one says, oh, John, you're on this list, but there's capacity at a hospital 100 kilometers away for that type of procedure. We can cut your wait time in half. So load balancing, not just up front in the referral process, but now after the fact. So what does that look like? It looks like this. It looks like a master wait list broken down by hospital, filter it, and you want to see endoscopies. Let's have a look at endoscopies. You want general surgery, whatever this surgical procedure or surgical service, and find out where your long waiters are. So how many of them are cancer patients waiting for a surgery? How many have waited longer than 3 weeks for their procedure? Where are they? This is, I won't go into the, because of the time constraints, the analytics, but again, understand in real time, this is updated daily in real time, where the patients are waiting and how are we trending by surgical service, by hospital, by region, by diagnosis, and have that for both waiting cases and completing cases. So you can see your trends over time. Again, much the same. This is taking the same data and being able to map the data and say, okay, show me those orthopedic cases that have waited longer than 6 months, 12 months, that are a level 3 priority, depending on your prioritization scoring. This is the region where it's being implemented, which is just across from Gatineau in the nation's capital region. And then finally, the ability, as I mentioned earlier, to say, okay, let's identify a cohort of patients that are long waiters, or we know they're about to be long waiters. Let's identify that cohort of patients. Let's look for capacity in the system, and then let's send a request from one institution, one hospital, to another to see if they can take up some of these cases. So every hospital can be a sender of cases or a referrer. Also, they can be a receiver of inbound referral requests or surgical requests. These are patients, again, that are already on a wait list for surgery. That's it. Merci.
Merci, John. Very interesting. And now we have Dr. Gagné. Dr. Gagné, à votre tour la parole.
So thank you very much. Thank you for the invitation to share with you our experience with clinical engagement. So my name is Pierre. I'm a nuclear medicine physician. I have a master in epidemiology, I've had 24 years of clinical experience, and I've been working with PowerHealth for the last 5 years. So today I'm going to talk how clinical engagement is an essential milestone in improving value. So quick note about our company. Our company is an international company. It's called PowerHealth. It's been allied with Telstra Health for the last 2 years. So we have over 25 years of experience in implementing IT solution in the healthcare system. So we're doing what we call case costing. So we often talk about value in the healthcare system. Well, the first step in assessing the value is looking at the cost. So what we do is we go into hospital centers, we take the grand ledger, the grand livre, and then we took those data, and then we took activity data being admission, discharge, outpatient visits, complication, accident, readmission, and then we put that into our software, and then we end up with costing data set. So the end result is that after that, we can end up and saying this patient, Pierre Gagné, was admitted for heart failure. We can look at the whole clinical care pathway and say Pierre Gagné has cost this hospital $4,200 for an average length of stay of 4.5 days. So that's what we do. So how come we were implanted in Quebec? We got a $44 million contract awarded in 2017 to do the costing in the healthcare system. That led to the creation of a local entity called Power Santé, and we delivered within budget and 6 months ahead of the 3-year deadlines, which, as you know, is pretty rare. And through this implementation, we integrated 1,800 different clinical system, financial system into our database, and of course, those databases are full of useful clinical data. So that's why we started to do a clinical engagement tour in collaboration with the Quebec Healthcare Ministry. We started that in 2018. It ended in 2020. And the goal was to promote the use of those data and increasing the quality of care, access to care, and safety issues, and to show clinicians how better quality of care can lower cost. So this is an example. These are anonymized data, and these were very few examples that we started to do. So we don't have much time, but just to show that we're able to look and drill down on, for example, coronary artery bypass graft surgery, the PAC, and look at, for example, number of episodes of care, the average cost, average age, average length of stay, average gravity, and number of readmission. So we're looking at quality, complications, and we're also looking at those data per physician, per surgeon. So to get a grip of what is the impact of harm in the healthcare system, what is the impact of that in losing value, I took a very simple example. We're talking about chronic obstructive pulmonary disease patients. So this was done into a real hospital somewhere in Quebec a few years ago, and the average cost that was assessed according to the same case mix, patient, the same, so my patient is not sicker than yours, it's exactly the same. So the comparison was of cost. You have on the left side the cost for without hospital harm, and on the right side the cost with hospital harm. And we ended up with a 1.4 times higher cost on average for COPD patients hospitalized when hospital harm occurred. So that might seem negligible when you look at it on a local scale, but scale that up to a provincial level, and then you can end up with what was published in 2019 in the Canadian Medical Association Journal. So the authors assessed what was the impact of hospital harm in Ontario for 5. Okay, for the 1 year, and the cost assessed was $1 billion a year. So just imagine how much money could be reinvested if we could do a small percentage of those savings in hospital harm. So that's what really led our clinical engagement tour. So we had meetings with heads of clinical departments, councils of physicians, dentists, and pharmacists across more than 20 integrated healthcare centers. We met with the 2 physicians' unions. We met with the Collège des médecins du Québec. We met twice with the General Assembly of Quebec Chief Medical Officers. We met with more than 20 steering committees of healthcare establishment, and we met with many other clinical associations, including Nursing Association and Pharmacists Association. And what we learned first is we need to adjust for comorbidities, the case mix, and show adjusted KPIs, because at times when we visited and look at the cost, for example, for general surgery for specific procedures, the answer were, my patients are sicker than theirs. So then we had to adjust that. At times was true, at times wasn't true. So, and we found out once we did that physicians are open to look at cost if clinical values, quality of care, access to care, and patient safety issues are put first before efficiency or cost-saving measures. For example, shorter length of stay and lower cost should translate into lower quality, shouldn't translate into higher readmission rate. Better performance should be a positive side effect of good clinical care. So contextualization is also critical. For example, often the best surgeon will perform the most difficult procedure. Classical example, cardiac surgery. We must also make sure we avoid penalizing clinicians that do most of the medical teaching. For example, their data for the time spent in the OR, skin-to-skin time, will be longer. And we found out that physicians are open if a safe and non-judgmental environment can be provided with data-based evidence. Just a quick note on value-based healthcare. Actually, we talk a lot about value and value, so the definition of value is the best achievable outcomes divided by cost for the whole trajectory of care. Now, of course, harm, adverse effect, complication, and other issues decrease value and consequently access to care. Now, what is coming in the future if we talk about value? Where in the future we're going to have to implement to measure other outcomes, other deliverables, such as patient-reported outcome measurement, patient-reported experience measurement, enhanced recovery after surgery, oncology database, and surgical complication database as well. So to achieve that, clinical engagement will be critical in getting this better value. And so just to conclude, we found out from experience that physicians are eager to improve quality of care and question the patterns of practice if provided with evidence-based and updated data, if detailed feedback can be provided, including drill-down analysis up to a specific patient, so they can rule out, for example, an outlier case that increased dramatically the average length of stay. If their core values are respected, if we keep a positive attitude such as focus on best practices instead of shaming suboptimal practices, and finally, improved performance should be seen as a positive consequence of the provision of better quality of care. Thank you.
Thank you, Dr. Gagné. Very interesting. Once again, Dr. Grégoire. It's your turn.
My turn. Well, I'm not selling everything. I'm not working on the bigger picture. I'm assistant chief medical officer at the CHU de Québec, and I work on the terrain. I work to try and have my patients operated upon. We've already alluded to the pandemic, to the waiting list, and I'm gonna show you a bit what that means. Before the pandemic, there was 120,000 patients waiting on the waiting list in Quebec. At the end of the pandemic, it was 165,000 patients. there were about 2,000 patients waiting for a hospital bed. They needed to be hospitalized to be operated upon before the pandemic. In last November, we were at 22,000 patients. Now, one of the big issues right now is those patients who have been the long waiters, and Jean-Frédéric alluded to that. The patients that are waiting for 300, 400, 600, 700 days on a waiting list. Those patients are important to the ministry, and we have to, in the different hospital, show the way that we can provide care to those patients who have been waiting. And this is a slide that shows what's happening at Chute Quebec. We started off, I can't see the exact date, there was 1,100 patients waiting more than a year. Mm-hmm. Most of them were hips and knee replacement and plastic surgery, obviously. And we are now at around 780. And why have we been able to do that? And why are we running around the province right now trying to implement what we have been doing in Chute Quebec to other hospitals? Well, these are the premises. This is the reality of Quebec. We have the lowest bed per capita ratio of all the countries of the G7. We have the lowest per capita number of beds over the different provinces. We are living right now with a crisis of patients who are in our beds and do not need acute care beds. Mm. They just need support. They just need other types of care, but not acute care beds. The number of surgical beds has gone down over the years. And although we've been trying to do all sorts of things to keep for surgeons their playground, what I would call their playground, it's not been happening. And I'm probably going to get into the social medias for saying what I'm going to say right now. But to a surgeon, emergency is the public enemy number one. Why is that? Because as soon as a patient is in the emergency room in Quebec, he gets priority. So, in fact, those patients who are at home waiting are not prioritized. And that's a big issue. And that's a point I've been making at my hospital. I've been saying that during the pandemic. I've been saying, you are forgetting all those patients who are on waiting list and belong to your institution. What are we trying to do to operate the right patients? During the pandemic, we organized a prioritizing committee, which was looking into every surgical schedule of every of the 5 hospitals in Quebec City. And we were putting on the schedule those patients that we were considering were not the most deserving, but the ones that were the most, that needed most to have their surgery at that moment. During the first wave of the pandemic, we weren't as lucky as Jean-Frédéric. We had 10 operating rooms open on 47. So you can imagine that we weren't operating that many people. So the waiting list went up. From that prioritizing committee in the pandemic, there's an offspring that we still working with. Is we call it le comité de vigie, the monitoring committee, or a steering committee that just distributes the OR time to the different services and surgeon according to the waiting list and according to the clinical priority that the surgeon has given a patient. Obviously, we've been calling about the ERAS programs, Enhanced Recovery After Surgery. It's been implemented a lot in colorectal surgery, my specialty. We're trying to do the same for all other types of very frequent surgery. Hips and knee replacement are definitely a goal. We need to try and do more patients. No more patients that were usually hospitalized. We need to give them services in outpatients. For example, I would have said to an orthopedic surgeon 10 years ago, you're gonna do a hip replacement in outpatient surgery. He would have laughed at me. But now, is it true? Now, it's more and more people are getting their surgery outpatient because we can't hospitalize them. But still, there are those patients that will not be able to get to outpatient surgery because of their comorbidity. We're talking about hospital at home, virtual follow-up. What we're doing in Quebec City, we're called URSA, which is a unit where we're gonna outside unit from the hospital, where we're gonna send patients who are stable after a hip fracture repair. Those patients have a very long length of stay of about 21, 22 days. So if we can send them to an outpatient housing or whatever, and just rehabilitate them there instead of leaving them in the hospital, we can use those beds to operate our sicker patients. And the one thing I've been saying to the minister, and at my place also, at my hospital, is we need to stop talking about beds dedicated to surgery. Beds dedicated to surgery means nothing, because whenever the emergency room is full, patients are going to be afforded their beds. What we need to say is beds dedicated to the OR, day in, day out, 10 bed, 12 bed dedicated to the OR. Whatever happens in the hospital, whatever happens in the emergency room, those beds are dedicated to the OR for the patients who have been waiting on waiting list for a long time. Thanks a lot.
Thank you, Dr. Grégoire. I have some following questions for you in turn. I have a burning question for Dr. Lévesque. You mentioned during your presentation that the private sector in Australia plays a large role in elective surgery. I think you mentioned like more than half of all the elective surgeries performed in the private sector. Would you say, and you've at the same time you've showed us a slide where you say publicly funded, privately delivered surgical care is a good way to alleviate the wait times in surgery. Would you say that it would be a good solution for our system where we have to tackle wait times in Quebec?
Always difficult to translate something that happens in a country without thinking about the conditions that make it a successful intervention. So first of all, you can be insured for medical services in Australia. So that really means that you can actually not have to pay out of pocket if you go to the private sector. Second thing is that clinicians can work in both systems, and therefore the private sector doesn't drain, or it does compete with the public sector to a certain extent, but many of the clinicians actually work in both sectors. And the reality is that the sectors are doing different things, okay? When we say that half of the surgeries are done, half of elective surgeries are done in the private, if we look at specific surgical conditions, it's almost all of them, because they're appropriate to be done in a very low technical kind of level. We're not talking about hospitals that have very big intensive care units and stuff like that. The surgical hospitals are a low plateau technique. It's so we stratify the system. We don't try to make them compete with each other. Almost all of the emergency surgeries, the surgeries that need to be done on the same day are done in the public sector, and therefore we really use those two sectors as a complementary sector. 40% of the Australian population have private insurance, so that means that there's a pool of people that can actually cross-subsidize very expensive surgery. That's absent here. And the last thing I'll say is that people with private insurance can actually use their private insurance within the public sector, so that the insurer has to bear the cost of care provided in the public sector, even though it's provided in the public sector. And that really creates that complementarity. It's a complex system, of course. As you know, mixed models of funding always makes things complicated. But in our case, it does provide a lot of checks and balances. If you don't have some of those key characteristics, then of course you've got the challenge of competing for resources, providing surgery in places that are not appropriate for it, and of course the public sector always being the backstop if patients are having complications afterwards. So I think it's important to work on the foundation of the system before we can actually really truly say that a large-scale implementation of private surgery would be a solution in the Quebec context. That's my feeling, having lived and worked in both systems and my recent experience in Australia.
Thank you. John, you've talked about central intake models that include centralized triage process. Am I mistaken, or it has been slow to adopt that kind of models in Canada? Are there barriers to the implementation of such models, and what are they?
Yeah, it's a good question. There are certainly barriers to it. There is some resistance to it. If we're being completely honest, some of the resistance comes from providers, practitioners, physicians. Some of them see it as a financial threat, that when the referrals come into central intake, you really need an honest and transparent broker at that point. Transparency of where the referrals are sent, and be able to back it up to show that you're not favoring one provider over another provider. So that there's that. There's also, we're very slow to change in healthcare in Canada. We refer to them as the champions of the status quo. There's lots of people, certainly up until the pandemic. I would say things have changed now, but up until the pandemic, there were lots of providers and people within the healthcare system, administrators, that the system worked well for them. It didn't always work well for the patients, as evidenced by the long queues for service. That's changed now. So I think we're seeing, for the first time, we're seeing a real appetite for change. And if you're not willing to change, you're sort of being pushed out of the way now. So there's new models of care that are coming. We're doing projects now, in Australia and in Canada, where people are willing to, for the first time, I think, really make transformational change on how the system will function. So those barriers are there, but they're dissipating now.
Oh, thanks. Dr. Gagné, I'd say you're a specialist of data, and we had the privilege to discuss prior to the panel about the way you collect data. There's a whole range of data. We simply underutilize our data. Am I wrong saying that? And what are the barriers to that? What are the solutions? I'm interested in having some solutions there.
Yeah, so for the clinician and the very busy managers, they don't have much time to look at the data. They need to be able to look at a glance at what are the relevant data, and these data have to be actionable data. I mean, number of beds per population, that's a great data, but we don't have, as a physician, any control in that, but we can have a control. For example, a real example of a chief medical officer somewhere in Quebec was following month to month what was the average length of stay for a COPD patient, for a heart failure patient, when there was some kind of change in the length of stay, dramatic increase, then he would walk the walk and go out to the internal medicine team and ask what's going on. And at times, say, well, we lack this resources to give discharge earlier. Oh, well, yeah, that's true. I might have been a little bit disorganized recently, so they could interact almost real time, actionable data, and have to be simply grasped in a moment. Now, the design of a BI tool to do this task is not simple. You know, it's, we look at, for example, an iPhone. An iPhone is simple. Everybody can use it, but I dare you to design a BI tool that a busy assistant medical chief or surgery, very busy, you know, is always managing crisis in the hospital, right? You're running around one place, running around, and he has to be able to look at a glance what's going on, what's right, what's wrong, how can I have action on that? And that's our goal to do that. And the next step will be afterwards, like I said, is we're looking forward. We talk about enhanced recovery after surgery. This is a way that patients have lesser complication, can get out earlier out of the hospital. We're talking about hospital at home. These are great initiatives, but bottom line, how can we measure success? How can we measure progress? What is the return on investment? How much it costs per patient? Is it better now? Is it getting worse? These are the questions we're trying to answer.
Feel free to step in. Dr. Lévesque.
Yeah. And what he's saying is extremely important because we're starting to finance surgery right now according to our performance, according to the number of cases we're gonna do in the hospital. So the data he was showing about the cost per procedure and the cost per doctor, I know the doctors won't be very happy about that, obviously, but this is the way to go. I mean, for example, hip replacement. There's a lot of companies who make those prostheses, and some are much more expensive than others. We need, at some point, to have doctors come together, decide what type of prosthesis, what are the advantages for the patient, according to the data that those companies will offer us. If we don't do that, we're going to keep spending all over the place. A lot of dollars. There's a lot of money in the system. There's enough money. Should be spent better.
So if I just can add up a few comments about that.
Sure.
So we had meetings with steering committee, la table des chefs.
Right.
La table des chefs. This is a place where you go and show data. You have clinicians that can be quite direct if you're doing BS. No, they can tell you. But what we did is that I'm not an orthopedic surgeon. Thank God for the patient. I'm not gifted at all, okay? But what we did is we showed the data, and we were non-judgmental, because I know that beside here is an orthopedic surgeon, in front is an orthopedic surgeon. They know their stuff. We just want to show data and start asking questions, because we know when we're going to leave, when the door is going to be closed, they're going to start talking together about your laggard. You know why? Can you correct it? Am I wrong?
Sure.
I just want to say that I think, Pierre, you're entirely right, especially when you talk about the need to implement patient-reported measures and outcome measures. We also need to link the data that we have with workforce data. Everybody talks about ratio all the time, as if this is not influenced by case mix either.
Yeah.
But the reality is that if you've got lower level of complexity of patients on the ward, well, you don't need as many professionals caring for it. And we don't at the moment link this kind of information as well. So it's financial, it's workforce, but more outcomes, because the data systems that we have in many countries actually never measure outcomes. Of course, we measure readmissions. That's a proxy of an outcome, unless, of course, you're readmitted for nothing. We take for granted that a readmission is an indication that somehow something went wrong with care. But it's much more powerful when you can actually talk to clinicians about revisions, infections, patients not being able to walk as much as they wanted, even though they got the surgery. You see what I mean? And we don't have the information infrastructure to do that, and it needs investments. In Australia, we've been investing in many of those systems, and now we're starting to be able to use it, and that also completely changes the conversation with clinicians to mobilize them.
If I may. We frequently look at surgery on length of stay. Length of stay is one data. The problem is right now with length of stay, and you're probably going to agree with that, is that with the fact that we're doing more and more surgery as a one-day surgery, our length of stay is not going to go down. It's probably going to go up, because the ones that we're going to operate are going to be much sicker. So we need to adapt and measure our length of stay with considering the patient who's operating day surgery has zero length of stay and included in the data. Otherwise, those guys like me are going to go to the surgeon and say, "What the hell's going on?
Yeah,
Your
I
length of
entirely
stay is
agree.
going up."
Yeah, all of the classic indicators are going to be redefined or needed to be redefined because of day surgery, but also because of virtual hospital at home and stuff like that. It's completely changing the denominator base, and many of the metrics are not actually at the moment adapted for that, and that's going to require a lot of work.
I just came from a conference yesterday in Toronto. It was an international investors conference on healthcare. And if you haven't heard of a company called Canary, you might want to look it up online. They're making Wi-Fi enabled devices that will be inserted in clinical trials now. They insert these Wi-Fi devices into the knee replacement, hip replacements, spine, and every night when the patient lies down, it uploads data that the clinician can see. This is all funded in the United States, so there's a huge financial incentive for industry to solve this problem. The metrics that they're collecting are absolutely fantastic. Be able to measure outcome, range of motion before surgery, after surgery, trend it, and right down to the complexity of each case, and you can bring it back to every surgeon too. So there's a whole new world that we're just on the cusp of being able to measure outcomes.
Well, I'd like to know if anyone in the audience would like to ask a question. Well, just feel free to go to the mic and ask them. So it could be in French as well. Dr. Grégoire, turning to you now. We had a discussion just prior to going on stage about the fact that there's some kind of a paradox where physicians, surgeons are in high demand for their service, but at the same time, you see operating rooms being open half the time. What's the problem? Is it a problem of central planning, of human resources? It's a waste of valuable resources, you have to admit it. What's the problem with that?
Well, there are several problems. During the pandemic, our worst problem was the patient who was testing positive to the COVID swab. So we lost a lot of time during that time. So we're relaxing a bit on this, but I would say that there's not that much time that's being lost right now in the bigger hospitals. The smaller hospital, I mean, in Saint-Anne-des-Monts, maybe we're not working 8 hours a day, 5 days a week. But in most bigger hospitals, I would say that, yes, they are. But there's one thing that we haven't been talking about. It's human resources. Human resources in Quebec right now is tumbling. I mean, patients are not patients, but the workforce is leaving the system to go work somewhere else. I mean, that's the reality. And we were talking about the private system, and I can understand the way you function. But here in Quebec, the workforce that's going to go into the private sector is the workforce that's working in the public sector right now. And that is one of the big issues that we're really concerned about. We're really concerned about this, because if we're going to lose our workforce that are going to be taking care of the sicker patient in the hospital for for the CMS or for whatever you may call it, for patients that are going to be less sick than our patient in the hospital, we're not winning anything. We're going to lose something. We're going to lose some more. So It's a balance. There's no one way. There's no one way to skin a cat, but we're concerned.
Yeah, and I'm concerned about an unregulated recourse to the private sector as well. I'll just give an example of some of the work we've done around low-value surgery, and that's something I talked about in Quebec City when I visited you. We all know that there are very clear criteria that enables us to identify that there's low-value arthroscopies, for example. And when we got on to not just measure it and reflect to clinicians that there was, very high rates of arthroscopies that were unindicated, really, and we got to try to address the problem, we targeted clinicians in a way that would address the problem in both the private and the public sector. Because you don't want to reduce low-value surgery in the public sector, but then in the private sector they just decide to still, put everybody under the knife without clear indications for it. And because we had that group of clinicians working in both sectors, really, we had a single target in terms of, who was it that we needed to change behavior from. We could talk to the private insurers to also bring them on board. They don't want to pay for surgery that's low value either. And we got amazing results in that place. But if it's two separate sectors that somehow don't have similar people, similar kind of funding structures, etc., there will absolutely be low-value procedures, surgery, and care provided in the private sector, because the driving force is different. So you need regulatory ways that will actually combine and bring back together those sectors for it to work. I'm concerned with workforce as well. It's the same thing in Australia, by the way. For us, of course, it's because we're a country of immigration, and we're importing a lot of healthcare professionals on a regular basis. We seem to be attractive.
I wouldn't mind being imported into your
place. Let's have a chat.
It's your beaches.
It could be the beaches. I do hope it's the good healthcare system as well. But the pandemic, of course, has closed the borders for us for a very long time. And as you know, I was stuck in Australia for 2 years without able to go, actually. And even between states, we were not able to travel. So it's been quite an experience, I have to say. But really, that meant that the usual 2% growth that we have in workforce that enables us to address the 2% growth in population was gone. And that really has affected us, in addition to, of course, people wanting a different lifestyle. And the rebalancing of the difference between the income that people make in healthcare versus other sectors. And that difference has reduced, which really makes healthcare less attractive for many professional bodies. So it is a real issue. We need to think about it, but we also need to think about the fact that in some areas it's an opportunity. Because when you have clinicians, when you have doctors, when you have nurses in the public sector, you don't fire them if you don't need them. You just use them again for other resources. And we know we need to shift to virtual, we need to shift to non-human based care in many different places. Where are the current shortages that will enable us to do that? Before we put back clinicians in the mix, let's ask ourselves if that's the right thing to do. And that's always a struggle, because both clinicians and politicians like to just put back resources and not really question if it's the right way to try to address the shortage.
Thank you. We have questions from the audience.
Yeah, my name is Michel Hébert. I'm a physician. You've talked about surgeries, and in the process from the patient who has a disease and will finally meet his surgeon, there's also a process of pre-op, selecting the patient, and that's the anesthesiologist's role. So I haven't seen any data, but what is the challenge in that section of the process from the patient? Did that contribute to the waiting list, or what do you see in actually and in the future for that particular section of the healthcare process?
Are you asking if the anesthesiologist is involved in deciding who should be scheduled for surgery? Is that the question?
Well, patients are proposed to have an operation, but before meeting the scalpel of the surgeon, he has to go through the anesthesiologist for many procedures. So what part those play in the process, and are they slowing down the process, what's coming up in the future for them, because that's the whole pre-op selection of the patient before being admitted to the hospital. So I see some concerns there from patients I refer. So I would like to know what is your experience on this.
So we work with lots of hospitals around optimizing that pre-surgical process, because the worst thing, of course, is that you have a patient that gets through, shows up for the day of surgery, and then the anesthetist says, I'm sorry, we need a chest x-ray, we need some preoperative test that's not there in place. So if you don't optimize that, you won't be very efficient with your utilization of your operating theater, your OR times. So there's certainly a connection there.
They've got a role to play in prehabilitation.
Yeah.
They've got a role to play in high-risk clinics to make sure that the patients that should not get to surgery are very quickly assessed and then rerouted towards a supportive care approach. That's fundamental to manage that flow, as well as the efficiency part, because again, that's about relevance of care, pertinence, des soins. It's the biggest hurdle, and it's the biggest pressure on our systems, and therefore at times you need that hurdle to be there. I know it can be perceived as another step in the process, but for many patients it's actually beneficial to have that, because they will not end up receiving a surgery that would have been dangerous for them. High-risk clinics and prehabilitation.
Yeah. Anesthesiologists are our friends most of the time. But they've been very instrumental in implementing those ERAS programs. Because when you do same-day surgery or those programs, those short stay program in the hospital, 3 things are important for the patient. The first thing, if he goes home, can he be taken care of by somebody if there's a problem? Is there somebody he can reach to ask a question or whatever? The second one is nausea. And the third one is pain. If you control pain, there's much more patient that can go home more safely. But if you don't do that, forget it. It's not going to work. So the best guys to do that, or the best girls to do that, are the anesthesiologists, and we've been working a lot with them. But like Jean-Frédéric was saying, and that's one thing that I'm regularly saying to everybody: if you have a surgical condition, it doesn't mean that you're going to have surgery, because maybe you cannot withstand the trauma of surgery. That's what Jean-Frédéric was talking about. Prehabilitation is a very terme à la mode right now, because you see a patient, for example, hip replacement in the clinic today, and then you're going to operate him maybe 400 days from now. He's not been able to exercise. He's not been able to walk. He's in a wheelchair. His quadriceps are that big. For sure, he's going to stay in the hospital. For sure, you're not going to be able to put him through one-day surgery. So you have to prehabilitate them. You have to make sure that when they get to the OR, they are able to withstand the trauma of surgery.
And just a quick point. Yeah, just a quick point in terms of anesthesia as well. The enhanced recovery after surgery program really also requires low intensive anesthesia, because the longer it takes for the patient to wake up after the surgery, the less likely they're going to end up being a day case. So it's about aligning processes, coordinating the care of the team, and of course that's not something that our systems are very used to do. So ERAS programs, fantastic way to generate that coordination. And in the entire continuum of care.
We should have ERAS program in the medical wards.
Absolutely. But that's more
Thank you.
challenging.
Your turn.
Merci. Thank you all for your comments and presentation. Just to make sure I'm well understood, I'll comment in French. Sorry, Mr. Sinclair. En fait, j'aimerais faire le parallèle avec la première ligne. C'est assez facile de voir les parallèles sur les bonnes pratiques, sur les problèmes. Ce qui est particulièrement décourageant, par exemple, c'est que ces modèles-là qu'on voit dans la littérature, qu'on voit dans des présentations, dans des colloques, sont rarement à la base des programmes qui sont mis en place à l'échelle nationale ou à l'échelle régionale. On les perd de vue complètement. On a des notions de gestion fondées sur le lean, fondées sur d'autres, je dirais souvent des buzzwords qui sont intéressants d'un point de vue de gestion, mais qui ne mettent pas à l'avant-plan ce qui fonctionne, le what works, qui est connu depuis très longtemps. Moi, j'aimerais savoir... On peut mettre la faute sur les patients, on peut mettre la faute sur les soignants en leur demandant de changer de comportement. Mais ce qui fonctionne, on le sait bien, puis Jean-Frédéric, tu connais bien ça en santé publique, ce qui fonctionne, c'est d'agir sur l'environnement. Sur quoi il faut agir dans l'environnement pour que ces programmes, ces conditions soient mises en place au plus haut niveau de notre système. On parle de value-based system, on parle de différentes théories qui fonctionnent, puis on les perd de vue rapidement. Et il me semble que plus on monte haut dans la hiérarchie, moins ils sont présents.
Yeah, go ahead.
Should I answer in French or English? Anyway, I think your question is an important one, and I think that the lack of scaling of a lot of those programs, because the reality is that everybody calls themselves the country that's champion at piloting. To be honest, okay, we think that that's a Quebec thing. It's not. You know, in Australia we say exactly the same thing. We're the land of innovation, but we just pilot it. The reality is that it needs an alignment of many different levers to actually sustain the implementation of those things at scale. There's funding changes that need to be aligned with what you want to do. There's workforce training. You need, of course, the right data. You need the right teams to have a sustained work with the clinicians to make it happen at scale. And then you need to be clear about what's non-negotiable. That's part of the model, okay? And everybody will need to do it. And what's the part that you can adapt and be more flexible about? And then you engage in the right conversation. I'm not someone that believes that there's 15 different models, you know, good ways to do everything. Usually there's 3 or 4 ways. And when people are outside of that, I say they're outside of the evidence base for organizational management, just like evidence-based clinical care. So you need to have structures that support that kind of change. It's not just by telling people or decreeing it in a law or whatever that this change happens. It needs to involve quite a lot of investment in working with people on the longer term. We always under-resource implementation. We always think that it's going to happen within an electoral cycle. And that's why I thought, you know, in my talk I would talk about the longer-term surgical changes that we are embarked on, and that's going to take, you know, many years, versus the very short-term things that we will do as well. It's very complex, but if you don't have structures and resources to support that kind of change, it's not happening. And I agree with you, then you just stay at the level of pilots, and many pilots that are successful then don't get sustained and scale afterwards, which is a very sad situation.
Okay, we have someone there. Yep, go ahead.
Yeah, I'll be short. Basically, maybe Dr. Grégoire, you'll like what I'll talk about. But about a year ago, I worked for a small startup, by the way, and we started a project with Le Chum in Montreal, and it was 2 anesthésistes in French that we started to work with. And what they were interested to work with us is to start a study on if we were using technology, which was our technology, once the surgery is performed, how can we actually follow up with that patient at home using the technology? And we've had over 500 patients that were followed up since we started the project. And basically 2 cohorts, 250 were followed up by our technology, and 250, basically, just about even, the traditional way. And what we were following up is exactly what you were saying, because the traditional way, basically, you'll call the patient day 1 after surgery, maybe day 3 after surgery, maybe day 5 after surgery, then nothing. But a lot of those problems starts much further down the road because the patient was not good enough to know exactly the pain level that he had, how to do that. But there was also another thing we do is education. We provide very little clips to help the patient learn how to take care of the surgery itself and how to recognize problem, but we do the follow-up much further electronically than day 1, 2, or 5. So those two guys, those two doctors.
Sorry, your question, please,
My
because the
question-
time is flying, and,
yeah,
and we'd like to have others.
But my question was more along the line, do you truly believe that using technology to do a follow-up after surgery at home can actually help improve the system?
Absolutely. Our colleagues from the CUSUM in colorectal surgery, Sandra Lieberman, has presented a paper some time ago where they've did 150 colonic resection in same-day surgery.
Mm-hmm.
This is major. This is major. Those patients usually get to the hospital, stay there, and in some places they stay there until they have their first bowel movements. It's not supposed to be, but it is. Now, and what they do is they have on their phone messages that come from the patients, where the patients can reach them and answer day and night the question of the patient. And this is the biggest issue. The patients are willing to do things, are willing to go home. They don't want to stay in the hospital. Everybody's would rather sleep in their bed and eat their own food than eat at the cafeteria. But that's the big issue, and I'm convinced about that.
The technologies like that are a force multiplier. We're talking about the human resources and constraints. We're talking about reducing length of stay and quality of care, and technologies like that, and there are lots of them now. It's spot on.
Thank you. Dr. Barrett?
Thank you for your presentations. I have a question that is addressed to both you, Dr. Lévesque, and Dr. Gagné, because the answer will probably not be the same. Number one enemy of any public healthcare system is politics, not policy, politics. That's what it is. And when we talk about politics in this province, we're talking about funding. And this week in La Presse, there was a very poorly written article, not the reporter, but the data that was published was absolutely poor. And in this country, and that's the way it is, both of you know that, when we come to compare the cost of any healthcare services that are provided in the publicly side of the system compared to the private side, although it is subcontracted, therefore publicly funded, there are always comments and whatever that will point negatively to the private sector. I'm not here to talk about favoring the private sector, but you, Dr. Lévesque, you are in a setting that is different from ours, but apparently it works well. You, Dr. Gagné, you are in this province, and I don't have to go any further, but there is one single question that has to be answered from both of you as precisely as possible. How do you compare the cost? And I'll go a little bit further. In 2017, Dr. Gagné, when you were chosen, your company, to put in place a system, I liked your presentation very much because you were chosen because you had the capacity, to have the proper granularity of the data to reassign indirect cost to a procedure. You can do that. Therefore, you can assess the cost of a service, whatever it is, provided in the public side as compared to the private side if the private side opens its books, which is the case in this province. But we still write things out stating that, well, one costs two more, and when you look at the public side, the data was not detailed properly or reported properly. So, the question is, how do you do that in Australia? Because I would be very much surprised that when you subcontract, you don't make that assessment. Is your assessment precise enough? And on your side, Dr. Gagné, just make a statement, just like Nike, just do it. You can assess precisely or a very strong approximation of the real cost on the public side. And then there will be a history. At this point in time, it does not exist in Quebec. Does it exist in Australia? And that goes not only for surgery, because the politics of things in this country, and the same goes in Ontario and everywhere, we do that also in primary care. We do everything when it comes to whatever is done on the public side and at the same time, concurrently, on the private side. So, have fun, tell me.
All right, quickly. The politics for us between the public and the private is not how much it costs, it's the inequity that it creates. And that's what is debated in the public. In terms of comparing both in terms of their financial effectiveness, the reality is that they provide such different services that both of them are actually compared to benchmarks, not to each other. And that's why the debate is very, very different from that perspective. The private sector tends to over-service all the time. You know, we've got people admitted to hospital for rehabilitation purposes, and the reality is that they're in hotels. But that's because they want it, they can afford it, they take it. So lots of inefficiencies in this way. Of course, for the public sector, we try to benchmark to other hospitals, the national weighted price. We've got activity-based funding really well established over the last 15 years that enables us to have that average price to be able to actually reflect on specific hospitals' financial performance. But private-public, from a financial perspective, not a question. It's equity. And we do want to care for equity. Of course, that's our challenge.
Okay. If I had to debate with you on this, I would say that's a good answer, but it's also political evasion. But you're not living in the same political realm. Because you can assess the cost. And my question is, can you assess the cost? I understand what you're saying, and you're right. I agree with you. But at the end of the day, or at the dawn of this day, you can assess the cost.
Of course.
Dr. Gagné.
Of course.
I'm a data guy.
Yeah, that's why I'm asking you the question.
So if you ask me what I would like to have access to those data, yes, along the trajectory of care, for example, elective surgery, along the whole trajectory of care, and have access to the data. I don't have access to the data.
You don't?
No. Private sector, no. I don't.
No. On the public side, you have access.
We had access. We had access to the data, but our contract, as you probably remember my presentation, we managed to finish our contract within 6 months of the deadline. Yes. So we don't have access.
But my understanding is that your system, because you've been chosen for that, so you had experience now. You have experience on our side, on the public side. If you have access, you can, because there are direct costs and indirect costs, you can redistribute, realign, reassess on the proper line.
Yep.
You can do that. So it is possible in this province for a given procedure to establish properly the cost that will be used to compare with the cost on the other side.
Yes.
The answer to that is a strong yes. Thank you very much. That's why I wanted to hear from you.
It's a great way to end this debate, because it turned out as a debate. There's a ticking red light, and it's always frightening to see that on stage. So I just want to thank our panelists. I want you to... There's one more question, maybe afterwards, because I don't know if we're allowed to... We are? Okay. If Dr. Barrette said we're allowed to...
Faut jamais se mettre en ligne en arrière de Gaétan Barrette pour poser une question, c'est sûr.
Ça, c'est sûr.
Merci. On a dit tantôt qu'il manquait une chaise à l'autre débat, c'est la chaise des patients. Il n'y a pas encore de chaise de patients ici. Puis je pense qu'il n'y en aura pas dans tous les débats qu'on va avoir aujourd'hui. On a l'approche de toujours aborder la question de l'accès aux soins de santé par le côté des structures, par le côté l'organisation pour le côté, etc. Et les patients sont toujours absents. J'ai entendu quelque chose d'intéressant. C'est Roger, mon ami. Je suis anesthésiste en passant, alors je suis l'ami de Roger.
De temps en temps.
Ouais. Pas mal de choses. Les patients des médecins, les patients des hôpitaux, les patients de tel hôpital, de telle clinique, les patients n'appartiennent à personne. Les patients appartiennent à eux-mêmes. L'esclavage a été aboli au 19e siècle dans la plupart des pays. On continue à tenir les patients esclaves de nos structures et de nos choses. Dans vos grands plans, in your plans of planning everything, having the right solutions, having the right structure, where is the patient? How will you measure patient satisfaction? How will you measure accountability of doctors, nurses, everybody to the patient? Because we're all here today because there is patience. We would do something else. We would do IT, we would do whatever. We'd be engineers, but we are all here because there is patience. How do you include them as a decider, as someone with a voice in the structures that you're proposing?
So if I may answer from my humble position, as we're actually, the big trend in the value-based healthcare, it's not only about words, it's to include the patient-reported experience measurement. For example, when I was hospitalized for my hip fracture, did the nurses listen to my needs? Yes, no, grade that, and then the patient-reported outcome measurement. As physician, if you look for example, a patient with cancer, first thing we look at from a physician perspective is the patient alive? Is he free of disease? But there are also other perspectives that are so important for the patient. That's why the future is near. It's about patient-reported outcome measurement. So was I able to walk fast after my hip surgery? Was my pain manageable at home? And the like. So this is the future we're looking at. And I totally agree with you from the patient perspective. This is one output we have to put into our database. Now, just to close on that, if we collect those data, then we have to be able to use them. And these data have to be actionable, measurable across the cost and other outcomes, such as survival, such as surgical complication and the like.
One of the challenges around PROMs and PREMs is who pays for it. So to collect that data typically has a cost associated with it. So different systems, we're not really incentivized or it's not really funded to collect that data. But without that data, it's really difficult.
We've got three ways, just to answer very shortly. First, we work on shared decision making and really are implementing this process in healthcare currently in our system. The second thing is that we've got 40 clinical networks that involve 2,000 clinicians, and that involves 200 patients that are part of the design of our models of care, because we commit everything to co-design with them. And then the third component is that we've got a platform called the Health Outcomes and Patient Experience Platform, the HOPE platform, and the word says it. We provide to clinicians at the bedside or in the clinical practice a system that enables patients to reflect on their outcomes and their experience. Before the appointment, after the appointment, it's all electronic, and it gives clinicians at the bedside that information, as well as collecting data that then can be used for planning. So it's not just, system design, it's also about the things that we do to influence clinical practice and change it. And of course, they're used a lot in anesthesia, surgery, as well as a lot of chronic disease management. So I invite you to look at the HOPE platform. The description is available on our website at the Agency for Clinical Innovation. It's a big implementation process, but we're doing it.
So, thank you. Thank you very much. Please join me in a big round of applause for our great panelists. And if you have further questions, you can, I think, ask them individually.